of Campinas. Today we have a special invited professor, Professor Matthias Oelke from University of Hanover. He's a friend of us. He stayed here some years ago, and this meeting will be coordinated by Professor Carlos D'Ancona, and clinical case will be presented by our senior resident, Natalia Avilez. Please, Professor Carlos.
Good morning, everybody. Welcome to our international urology meeting without frontiers. Today we have a special invited Professor Matthias Oelke, very kind to discuss the case today. And we start discussing two cases, and after we have a presentation of Dr. Matthias, a very interesting topic, fake news in BPH. So, Natalia, please start with the first case.
So good morning, everyone. I'm a senior resident here, and I'll start with our first case. Okay, so our first case is a male 52-year-old. He came to a routine consultation with some exams. And when asked, he says that the urinary stream is weak, but doesn't bother him. He wakes up once at night to urinate and has no antecedents. At the digital rectal examination, shows a 50-gram prostate, fibroelastic, and without nodes. His PSA level was 1.4 with a normal renal function. The ultrasound confirmed a 50-gram prostate and a bladder with thickened and trabecular walls with signs of straining bladder, and a post-void residual volume of 80 milliliters. So we started tansulosine and finasteride and reevaluate after 3 months. After 3 months, he discontinued treatment and complains of ejaculation disorder. He said that has a decrease in ejaculate volume and expresses an additional concern. He has a partner who is 20 years younger and wants to get pregnant.
I'd like to ask to Dr. João, our fifth grade resident, which complains of this patient have some modification in the ultrasound of the bladder appearance. What's your suggestion for this case?
I think this patient, he has a bladder wall that it's changed because of the obstruction, but he's a young patient and he has not big complaints about his function. So about this, I think the medical treatment, it's okay, but the problem now is the ejaculation disorder. I think we can change the tansulosine for doxazosine. It may be better for this disorder.
Okay. But the alpha blocker normally have some effect on the ejaculation. And the patient want to have a younger wife and want to have a child, pregnant. So, Matthias, you have some consideration in this case, a little, not very big border, but have a modification of the bladder. So you have some concern in the future this bladder can decrease the contractility, have some effect in long way. What's your suggestion?
Well, first of all, thank you very much for the invitation, Carlos, my dear friend. I stayed in Campinas 10 years ago and enjoyed my time very much. This is a typical Brazilian case, 52 years old, wife 20 years younger. This is rather untypical. Most probably is his second wife, right? So this does not happen in Germany so frequently. This gentleman has some voiding problems, but I would like to know if the voiding problem bothers him, or is it only the concern that kidney function, bladder function becomes worse over time, or if he has prostate cancer? Because when you ask the patient why he visits a doctor, it's frequently the fear of prostate cancer. So if his voiding symptoms exist and don't bother them, I wouldn't do much at that case. However, if he needs treatment and he has complaints about his voiding function and his wife wants to become pregnant, we can consider PD-5 inhibitors, which increase erectile function or improves erectile function and has almost the same effect than an alpha blocker. That's my idea.
He doesn't have any complaint about the voiding function. Just when we asked him, he said that it was a extreme urinary, but he wasn't bothered about this. We just be concerned about the ultrasound bladder changes.
Yeah. I will provide some specific information about the bladder wall and bladder wall trabeculation in my presentation. And I think he doesn't have to be afraid of the bladder wall trabeculation. It's just a sign of something different. It's not obstruction most of the time. So I will explain in my presentation a little bit later.
Cassio, you asked to perform urodynamics to have some functional information in this case.
I agree that he's not so concerned about the intensity of voiding symptoms. So it's kind of premature to indicate aerodynamics. I tried to indicate it when I plan to change the treatment or to propose something invasive. But it's an option because for an ejaculation disorder, trends goes to another kind of treatment, more invasive. So I propose aerodynamics for this situation only about this.
To ask to Jefferson, our 5th-year grade, because this patient his wife want to be pregnant. You suggest or consider the patient have some conservation of sperm for the future necessity?
So you ask if he needs to take the sperm, you say?
Sperm, yes,
Yeah.
to freezing the sperm.
No, okay. He's 52, but the wife is really young, so it's possible to wait and try another treatment. And if it's not possible, for example, some minimum invasive treatment, if we want to keep on the line that we are not going to suspend the medication, we are going not change to doxazosine, and we are going to do a more invasive treatment, we can wait. The wife is young. Despite the fact that he is 52, his sperm count's probably good yet.
Yeah, we have to consider, Carlos, we have to consider that an operation mostly causes ejaculation disorder or unejaculation. There are some minimal invasive treatments, like the UroLift system, that doesn't do that. Or we have a ejaculation-sparing TURP with a chance of 80 to 90% preservation of ejaculation. So we really have to counsel the patient, especially because the wife wants to become pregnant. So I would not do an operation as first line or second line treatment in this gentleman. He will be unhappy, huh?
Yeah, the EAU guidelines recommend a prosthetic urethral lift for patients with benign prostatic hyperplasia who wants to preserve the ejaculatory function. So we did perform a prosthetic urethral lift, and the patient is satisfied and with no complaint now.
Congratulations.
Any comment on this case, Matthias?
Who pays for the UroLift procedure? The government or the patient himself?
At our university, the government pays.
Okay, because in Germany, it's not a treatment that's paid by the health insurance. Patient has to pay himself.
So the patient don't want to do this procedure?
Most patients reject this procedure because they have to pay a lot of money.
Yeah. Next case.
Okay, so our next case is a 78-year male. And he refers one acute urinary retention episode a week before and is using a vesical catheter since then. He presented LUTS in the past year with no treatment, and as antecedents, he has hypertension, congestive heart failure, and present an acute myocardial ischemia 1 month before, treated with a staplement, and now is using aspirin and clopidogrel. The digital rectal exam shows a large prostate, fibroelastic, and without nodes. His PSA level is 2.1 with a normal renal function. So the ultrasound showed a 90-gram prostate with a median lobe projecting 14 millimeters into the bladder and a bladder with thickened walls with a 4 millimeters detrusor, suggestive of straining bladder. And he also got a post-void residual volume of 400 milliliters.
Let's go back to João. So, patient now is a big prostate, have a cardiac problem, and have some contraindication to perform some kind of surgery. So, what you suggest to this patient? Put a cystostomy, go back to home?
It's a possibility, but I don't think it's the first option of treatment. I think we have to talk with the patient, show the possibilities. And for this patient, this thickened wall and this post-voiding residue, I would take in a urodynamic study for this patient first to decide the treatment after.
But you don't try to start with alpha blocker and take the catheter out?
Yeah, it will not be my first option because of the residue 400 milliliters. So not at this moment.
Okay, you have the urodynamics, João asked.
Yeah, we got. But here we try pharmacological therapy. We prescribe tensilosin and finasteride. And then we ask a urodynamic study and also a preoperative cardiologic evaluation. So after 3 months, he returned and complains of 2 episodes of cystitis in this period. And we perform an unsuccessful attempt to remove the vesical catheter. The cardiological assessment advised to not suspend the dual antiplatelet therapy for at least 6 months and, if possible, a year. The urodynamic study shows normal sensitivity, no contractions on cystometry, and good compliance, and a cystometric capacity of 550 milliliters, and shows a bladder outlet obstruction.
So, João, what you asked, aerodynamics, really obstruction, have a contraindication for surgery, and he's have complication to stay with catheter. So now?
Yeah, I think we can talk with the patient. The option that you gave us, it's a possibility, the cystostomy. We can also talk to the patient about catheterism. He can do it by itself, because surgery to be not a good option for this patient.
So, Matthias, you have good experience with new techniques like Urolift, I-Tind. You think this new mist can be used or have good results in this case of patient?
What you can try is, if available, a green light laser, where you don't have to stop the anticoagulation. I would most probably not done a urodynamic investigation because it's so clear with an IPP of 40 millimeters in the thick bladder wall, the chance of bladder outlet obstruction is pretty high. And when he's in retention, we go for immediate surgery. In this case, we have to be a little bit careful because he has some cardiologic problems, but a green light laser would be a good option if he wants immediate treatment.
Okay. Lucas going to have a question. Please, Lucas, go ahead.
Okay, thank you, Professor. I think this case would be interesting, or could be an option to do prostate embolization. What do you think, Dr. Matthias, and do you have experience on that? Thank you.
No, that's a radiological treatment. It's not done in my hospital, but the results are in favor of that type of operation. It's mostly not immediate relief of symptoms and voiding, but it's a treatment option, yes. But it's done very rarely in Germany. We have only like 5 or 6 hospitals, and the total amount of prostate embolizations is in the range of 200, 300 patients in Germany, and we have 83 million people in Germany. So it's a very rare operation.
In this case, you perform an embolization. How long decrease the symptoms? For how long is the treatment is effective?
Well, in the long term, it's effective, but it takes some time to build out the necrosis and the sludging of the necrosis. So it takes a couple of weeks, if not a couple of months, that you can remove the catheter. You have to try it. In that case, I would put in a suprapubic tube just to test voiding and post-void residuals.
Okay.
So in this case, we perform a prostatic artery embolization. Here we can see in the first image the superselective catheterization of the prostatic artery, and on the right side, after embolization with no flow.
Yeah. Do you do it on one side or on both sides?
Both sides.
Both sides. Okay.
The vesical catheter was removed after 1 week, and the patient had spontaneous diuresis and is satisfied.
Okay. Now we want very excited to wait your presentation about fake news in BPH. So I want to hear you, Matthias. What is fake? What is true? Please, Matthias, go ahead, your presentation. Matthias?
Yeah, just wait a second. I have to start.
Perfect.
I think I got it here. Let's see if it works. I think it works, huh? Can you see it?
Yes.
Okay. Here you can see an image of my hospital. I'm not in the university anymore. I'm here in a peripheral hospital, but it's extremely well known for robotic surgery. We perform about 2,000 radical prostatectomies per year, but only with robotic surgery. And in the middle, you can see our building. That's only urology, and you can see here the urology wards and the operation rooms on the top. And very famous is the chairman of the department, Jörn Witt. And he is the founder of this department, and it's really well known in Europe for robotic surgery in 5 operation rooms at the same time, 5 days a week. So that's about my background. So I would like to talk about myths or fake news. And fake news are well known from the former president Donald Trump, and you can say damn lies or liar, liar, pants on fire, or where the truth ends, the fake news starts. And I would like to talk about the fake news on BPH. So I would like to aim some things, and I would like to identify the fake news on BPH. And today I would like to present 15 myths, but there are more available. We always have to consider that BPH is the 4th most common disease in men aged 50 years or older. So it's behind the arterial hypertension and cardiovascular diseases, the most frequent disease in men 50 years or older. In Germany, with a population of 83 million, we have about 5 million patients who are affected by lower urinary tract symptoms, and the health insurance pay about 2.2 billion euros per year, and you have to multiply, I think, this by 5 or 6 to have it in Brazil reais. So it's a huge amount of money that we spend on the assessment and treatment on BPH. So therefore, you can assume that the majority of urologists, either specialists or residents, but also GPs, are extremely familiar with that disease. And obviously it's not the case, and I would like to find explanation why the fake news persist in the urologic communities Although these facts were also proved wrong 20 to 40 years ago. So they persist in the community, although proven wrong long time ago. Let's talk about some fake news on anatomy and pathophysiology. What you can find in the German textbook of BPH, it says a normal prostate has a size of a chestnut and a weight between 20 to 25 grams. And you have to know that chestnuts are very common here in Germany, and I've even grown up in a street called Chestnut Street. So I'm very...
Sorry. Can you hold a little bit, please? We have
Yes.
a technical problem here. A little bit.
We can see screen, not your slides.
You can
Just
see
as
my
the first
slides.
slide, not to move with your presentation. You can enlarge your screen.
It's completely
Or
enlarged.
maybe if you're using two screens, maybe if you use only one, will solve the problem.
Let me see if I...
Professor D'Ancona, o slide, a apresentação do professor Matthias não está em modo apresentação. Ele tem que botar em modo apresentação.
Nós estamos vendo isso para ver se a gente consegue.
É isso que está acontecendo. Agora ou ele pode passar slide por slide clicando em cima deles aqui do lado.
Matthias, in the bottom you see your screen, full screen.
Can you see it now?
Yes, I can see. So you also can change slide by slide. So you change the slide by slide, so you see.
Yes.
I don't know if you're using two screens. We see your screen where you have all the slides. So we see the PowerPoint screen and not the presentation
You are not at the presentation mode.
for us.
Yeah.
Can you see it now?
This button. This button.
Devia ser.
Please give me feedback because I cannot see you. Can you see the screen with fake news number 1?
Yeah, now you can.
Yes.
Okay. Let's keep on trying. If something goes wrong, please let me know, okay?
You change your slide every moment you want. It's better.
Okay.
Thanks.
So the fake news number 1 is one that's from German textbooks of urology, and it says a normal prostate has a size of a chestnut and a weight between 20 and 25 grams. I've grown up in a street called Chestnut Street, and I know exactly how a chestnut looks like, and you can see an image here. There are different species of chestnuts, and what's wrong that there is the size of a chestnut because you have small chestnuts, big chestnuts, and they are different in different species, and even in the same species they have different sizes. So the description of a chestnut is definitely wrong, but what's right that the prostate has the configuration of a chestnut and is very similar to the human prostate. It's a heart-shaped, concave on the dorsal side. So that is actually true. Let's look now at the correct unit of prostate size. You can see the ultrasound image now?
Yes.
Okay. And from the presentation of Natalia, I saw that you're using it wrongly as well in Brazil. I'm sorry to tell you. So what we do is when we measure prostate volume by digital rectal examination or transrectal ultrasound, this size is based on the measurements of length. And therefore, when we have the length, the width, and the height all in centimeters, either by the finger or by the ultrasound, then it's the unit cubic centimeters. The unit of milliliter refers to a volume of liquid, and the weight, like Natalia has provided, refers to the measured weighted scale. So you put it on on the scale and you weight it like you do it after TURP. That's gram. It's always assumed that 1 cubic centimeter is 1 milliliter and 1 gram. Theoretically, it's true, but there's no scientific evidence. So when we measure by ultrasound or digital rectal examination, then the correct unit is cubic centimeter. When we do a TURP and we put it on a scale, then the unit is gram. So the normal size is a chestnut and weighs 20 to 25, actually now cubic centimeters. Let's have a look at the average prostate volume in meta-analysis of an autopsy studies. So there was a very famous publication by Professor Berry from the US in 1984, and he put together almost 1,000 patients evaluated by weight in prostate autopsies. And he can see, and you can see here, that a normal prostate is very small at the beginning. But in puberty, it grows and remains more or less stable in young adults. And the average weight is 20 plus minus 6 gram. And with BPH, we have an increasing volume with the elderly patient generation. So therefore, everybody says the normal prostate weight is between 15 and 25 grams. But that's actually not true. And I will show you now one of the original studies that was also included in the meta-analysis. And this is published by Dr. Swire from the US in 1944. And this is one of the individual studies. And what you can see here, the open points, the white points, these are the prostates in gram with no microscopic BPH, and the black dots are those with BPH histology. And you can see when you look at the white points, you can have some patients or some people with a large prostate of 40 grams, but also low prostate grams like 8 grams. So actually, the normal prostate size is not between 20 and 25 grams. On average, is true. But in the individual patient, you can have a prostate of 8 grams or 30 grams or 40 grams, and that's still considered normal. Beyond 40 grams, you clearly have a BPH. Fake news number 2 is benign prostatic obstruction. So bladder outlet obstruction in the case of an enlarged prostate is evident in large prostates. And that is proven wrong since 1995 because from the Dutch working group Peter Rosier and Jean Delarosette, it was shown in a urodynamic study comparing bladder outlet obstruction and prostate volume that there is an increase of the chance of bladder outlet obstruction with increasing prostate volumes. But the chance of real obstruction in a prostate 100 cubic centimeters or bigger is only 40%. There is minor obstruction, which you don't have to treat by surgery, another 40%, but there is no obstruction still in 9% of the prostates. So you cannot automatically assume there's a large prostate, 100 gram or 100 cubic centimeters or bigger, so he's obstructive. We have to test in every patient individually if he has bladder outlet obstruction or not. Fake news number 3, bladder outlet obstruction can be diagnosed by urethral cystoscopy. And here you have a scheme where you see the bladder and the prostate. And these are different types of bladder trabeculation. And this is no bladder trabeculation. Severe bladder trabeculation is grade 3 with a diverticular, that's number 3. And here you have the occlusion of the prostatic urethra. You go to the verumontanum, you open the rinsing system, and you can see small lateral lobes. They're open, they don't touch themselves, grade 1. Grade 2, they open, they don't touch, but grade 3 are kissing lobes. So almost all urologists, at least in Germany, will tell you, oh, we don't have to do a urodynamic investigation because this patient, number 3, or this patient, number 2 and 3, are clearly obstructive. I show you now the urodynamic data according to trabeculation grade. And you can see, and this slide is here in German, trabeculation grade, that is blue, dark blue is obstruction. The light blue is is minor obstruction and white is no obstruction. And you can see that with increasing trabeculation grade, there is an increasing chance of bladder outlet obstruction, but it has only a chance of 78% if you have diverticular. If you now look at the occlusion grade and you take the highest occlusion grade with kissing lobes, you have a chance of 56% that you have bladder outlet obstruction. That's the chance of almost 50-50. You can flip a coin, so it tells you absolutely nothing. The message is you cannot diagnose obstruction by urethral cystoscopy like everybody does in Germany. So that's completely wrong. Fake news number 4 is bladder trabeculation is caused by detrusor muscle hypertrophy. And you can see here one image or another image. You can see these trabeculations here in the bladder. And it's called a bulky bladder in Germany. And everybody says, okay, that's a clear sign of bladder outlet obstruction. But that is actually not the case. You can see it in many patients, about 1/3 of patients with clinical BPH. But when you look microscopically or by ultrasound, you can see that bladder trabecula consists of collagen and elastic fibers in the mucosa and submucosa of the bladder wall. And here you see one of my transrectal ultrasounds. You can see here the detrusor, that is a detrusor. And here you see the mucosa and submucosa. And here you see the bladder trabecula that has absolutely nothing to do with the bladder wall, with the muscles, has something to do with deposits of collagen elastic fibers in the submucosa. What we now know, and that is a very old information from 1985, it was shown by Paul Abrams from UK, that bladder trabecula are a result of detrusor overactivity and not a result of bladder outlet obstruction. So when a patient, maybe even a female patient, has detrusor overactivity, we can see these bladder trabecula as well. Again, has nothing to do with a detrusor, has nothing to do with bladder outlet obstruction. However, there's an increasing probability of detrusor overactivity with increasing age and BOO grade. So you can see in our own investigation with more than 1,400 BPH patients, and you can see they were all evaluated by urodynamics, and you can see the Schaefer class from 0 and 1, no obstruction, minor obstruction, and different grades of obstruction ranging from 3 to 6. And the dark bars represents the probability of detrusor overactivity in these groups. And you can see an increasing chance of detrusor overactivity with increasing bladder outlet obstruction grade. Moreover, with an increasing bladder outlet obstruction grade, there is an earlier appearance of detrusor overactivity and a higher amplitude of this involuntary detrusor contractions, which we can show in this urodynamic study that was published some years ago. I would like to bring to attention, these were unfiltered patients because everybody who entered the department at the University of Hanover from 1992 to 2001 including, they had all urodynamics. And here you can see the number of patients investigated in each group. And now you can see the chance of bladder outlet obstruction in these groups. 0, 20%, 1, 22%, 2, 21%, and very minor obstruction is 17%. So you can see in 20%, there's only real obstruction in these patients where we believe they were all obstructive. So obstruction is most probably not so common that we think. So then the next fake news is the nomenclature of diverticular and pseudodiverticular. And you can see a cystography where actually that's an IVB, and you can see still the contrast media coming from the upper urinary tract and the bladder filling with contrast media, and you can see here a diverticulum and here a diverticulum. So the question, is it a diverticulum or is it a pseudodiverticulum? In Germany, we would say that's a diverticulum and these are pseudodiverticula. Well, actually, it's exactly the other way around. When you see a true diverticulum, you can see it consists of all parts of the bladder wall. of the mucosa, diffuser, and adventitia, and that's a true diverticulum. That means that we name the pseudodiverticulum wrongly, because that's actually a diverticulum and vice versa. Here you can see a pseudodiverticulum, and you can see the adventitia and mucosa going through gaps of the diffuser, exposing to the lateral side. So again, patients with diverticular, we name them diverticular, actually pseudodiverticular. As you can see in this lower image, it's a voiding cystography. You can see the bladder here with the prostatic urethra, and you see the big pseudodiverticulum. And during voiding, you have a ballooning and an increase of size of the pseudodiverticulum. Then the patient empties completely, the bladder is completely empty, but the contrast media stays in the pseudodiverticulum. So we use the word diverticulum and pseudodiverticulum correctly, not correctly. We use it in the wrong way. It has to be vice versa. A diverticulum is actually a pseudodiverticulum. What very popular is in Germany, it's the assumption that the BPH disease progresses in stages. And we had a very nameful professor. It was Professor Oelke. And Professor Oelke was the godfather of urology after Second World War. And he published an article, no, actually he published a book in 1955, where he said there are 3 stages of the BPH disease. Stage 1 is the irritative state. There it starts all the time. It starts with symptoms, especially with frequent voiding and nocturia, and there's no evidence of post-void residual. Then it goes to stage number 2. It's called compensated urinary retention. There's increase of symptoms and an increase of PVR, but it has to be between 50 and 100 cubic centimeters, and there's a reduction of functional bladder capacity. In stage 3 is a decompensated urinary retention. It's acute or chronic retention with overflow incontinence, decreasing kidney function, bladder trabeculation, and pseudodiverticular. And he said it's going from stage 1 to stage number 3. That is actually believed by the majority of urologists still in Germany, because this one article was republished and cited in textbooks and so on, and never ever somebody doubted it. So the first problem comes with the name of the Oelke stages, first described in the German literature in 1955. With a friend of mine, he is a historian of the German Society. It's Professor Moll from Cologne. We questioned that, and we found out that the stages 1 to 3 was not actually described by Oelke in 1955, but by a French urologist, Jean-Casimir Guyon, already in 1888. So Professor Oelke copied the theory of Professor Guyon, that was like 70 years later, without citing him. So actually, these are the Guyon stages, which are still named Oelke stages in German literature. However, we know since 30 years that this is not a linear development, that we have to see LUTS, prostate enlargement, and bladder outlet obstruction independently, and have to define in each patient if he has LUTS, BOO, or BPH. So it's not a linear relationship, it's a coexistent relationship, and stage 1 does not automatically go to stage 2, and stage 2 doesn't automatically end up in urinary retention. That is something we have to be aware of. Fake news number 8 is PVR, are mostly caused by the prostate, especially in older men, because there is a prostate enlargement and there's automatically BO. We have to be aware there's a multifactorial etiology, that it may be diffuser underactivity, idiopathic, myogenic, neurogenic, iatrogenic, that it has anatomical reasons, for example, diverticular, pseudodiverticular, or maybe a reflux, and has something to do with the bladder outlet, mechanical or functional obstruction. What we have done in Germany, we have a huge epidemiologic study where we have studied more than 8,000 men. And what we have done, we have taken away all the men who are patients. We are taking away all the patients who who have been treated with some drugs and see the normal population untreated, and we can see in the different age groups that there's always a little bit post-void residual ranging from 24 to 32 milliliters with a standard deviation up to 50 milliliters. So PVR is quite normal in the German population, especially in men. But this does not mean automatically that there's always obstruction. What we know in men with BPH, there's no or very low correlation between PVR and symptoms, obstruction and prostate enlargement. And the high PVR, which some people assume it's obstruction related, especially more than 300 milliliters, are more likely to be a sign of diffuser underactivity and is highly associated with a worse outcome after TURP. Fake news number 9 is PVR causes urinary tract infection, especially recurrent urinary tract infection. However, this is no or low correlation between PVR and urinary tract infection in these publications. And in a recent publication with 98 elderly men in nursery homes, so very old and sick people, there was no correlation between PVR and urinary tract infections. And here you can see the gray bar, these are patients or people without urinary tract infection. The red ones are people with urinary tract infections. And you can see that even in lower or in higher ranges, the patients with urinary tract infection have no association with the amount of post-void residual. And when you look in absolute numbers, the patients without urinary tract infection actually have higher PVRs than those with recurrent urinary tract infection. So it does not mean that you have PVR and the patient has automatically urinary tract infections. Fake news number 10, we have to operate the patient because PVR is a precursor of urinary retention. And we can have a look at the MTOP study, this famous study where the patients were treated over 5.5 years, either with placebo, with an alpha blocker, with 5-alpha reductase inhibitor, or with a combination therapy. And when you look at data on post-void residual urine, and these were the average numbers below 39 and above 39, there's a tendency in patients with higher PVRs that there's a general progression, symptomatic progression, and a chance of invasive BPH therapy, but there is no association of PVR and urinary retention. So PVR is actually not a precursor of urinary retention, as MTOP's data have shown us. Here you can see a study with bladder outlet obstruction in men with acute urinary retention. And all these people received a urodynamic study. And you can see that the PVR amount is actually much higher in patients without bladder outlet obstruction compared to those with bladder outlet obstruction. So these people most probably have diffuser underactivity, and these have BOO, but patients with diffuser underactivity have higher PVRs. So the conclusion is there's a low correlation between PVR volume and urinary retention. Let's go to the fake news in medical and surgical therapy. Especially in Germany, we assume that the entire transition zone has to be removed during TURP, and that's obviously not the same philosophy in the UK or in North America, but we have to remove in Germany the complete transition zones, and there are different techniques, the Barnes technique, Nesbitt technique. We follow the Mauermeier technique, and you can see the Urolift system where we don't remove anything. What we want is an open area between the verumontanum, and you can look in the bladder, and this looks in reality like that, verumontanum, and you look straight in the bladder, and that is the situation. It has to be. But when you compare that after complete TURP and compare this with the Urolift system where you just open with small strings the anterior part of prostate, there's a huge difference. And the question is, do you have to do radical TURP or do you have to open just by channel TURP by Urolift? And that's an open question. And here comes a study from Brazil, published in 2009. This was a prospective investigation of 88 patients with BPH and BOO, and they compared the resection rate, which was preoperatively determined, then less than 30% of the prostate volume, between 30 and 50%, or more than 50% of the prostate volumes. And you can see the results at 3 months. And you can see, according to the resection rate, there's obviously a decrease of the PSA level, but there's absolutely no difference in IPSS score, IPSS quality of life, and nocturia. So they are all insignificant. And that means you don't have to remove the entire prostate in the short term after 3 months. I would have wished that this investigation was redone with a longer follow-up to see if these values change over time. But the 3 months value tell you it's not important how much part of the prostate you remove. So then there is a question on the consistency of outcome after partial TRP. Some people will tell you when you have only a partial TRP, like a channel TRP, the patient will develop the same symptoms over time, or even might have urinary retention. And that was investigated in 1994, or even earlier, was published in 1994. It was done in 167 patients in Denmark who were randomized to partial TRP, a channel TRP, and total TRP. And they re-evaluated that 10 years later, and they could find, or were still alive, 29 men with partial and 33 men with total TRP. And the result was there was a significant improvement in bladder storage and voiding symptoms in both groups over time after 10 years. There was a significant improvement of maximum urine flow, consistent in both groups, no difference. PVR significantly was reduced in both groups. Total TR groups was a little bit less. The reoperation rate was identical, and the authors had the conclusion that partial TRP is a recommended alternative to total TRP. That it means even after a long time, a partial TRP is efficient. So many people in Germany who don't like urodynamics say there's a preoperative verification of bladder outlet obstruction is not necessary because all men will profit from a prostate operation automatically, and they're all the same. Either they're obstructive, non-obstructive. And this topic was further analyzed by meta-analysis from Korea by Professor Kim, and he looked at 19 studies published between 1989 and 2014. And he compared these urodynamic data in favor of IPSS. And you can see the IPSS values in this forest plot. And you can see that patients who were obstructive at the beginning before TRP did significantly better than patients who were not obstructive in urodynamics. The mean IPSS difference is about 3.5 points in favor of the obstructive group. When you look now at IPSS quality of life, you can see that the patients who were obstructive at the beginning were clearly better, and that IPSS quality of life difference was 0.6, and that was clearly significantly better than unobstructed patients. When you looked at Qmax, it was also in favor of the obstructed group. These people had a Qmax of 3.9 milliliters per second, better than the unobstructed, and even PVR was significantly better, was almost 33 milliliters better in the obstructed group. Therefore, it tells you that when you determine bladder outlet obstruction and you do only a resection or operation in the obstructed, you will get significantly better results in these obstructed compared to unobstructed patients. The same discussion is, what do you do with patients who have diffuser underactivity? And we have long-term results from Dr. Thomas. This is a lady who worked with Paul Abrams in Bristol. And he looked at all urodynamic data and looked at the long-term results of maximum urinary flow at diffuser pressure at maximum urinary flow, a urodynamic parameter, looked at voiding efficiency, PVR, bladder contractility, and LUTS in men with diffuser underactivity. There was a clinical and urodynamic evaluation before and after treatment with a follow-up of 10 years. So everybody had the urodynamics at the baseline, and at more 10 years afterwards, they did a re-investigation of urodynamics and clinical follow-up. They divided the groups in men with diffuser underactivity treated with TURP and found out that all parameters were unchanged after a median follow-up of 14.5 years. So preoperative data, and after 14.5 years later, there was no difference in any of those values. Men with diffuser underactivity, that's the second group, with only watchful waiting, so no TURP. These patients and all parameters were unchanged after a median follow-up of close to 14 years. So there was no difference between the groups in all these parameters. When you now compare the first group against the second group, the comparison then found out that patients after TURP have a significantly lower bladder outlet obstruction index because of TURP, but PVR was significantly higher, voiding efficiency significantly lower, and more patients had chronic urinary retention, and I assume also bladder neck stenosis as well. So the patients who were treated by operation, in this case TURP, did worse after long-term outcome. The conclusion of these studies was TURP is an inadequate treatment of diffuser underactivity, and preoperative urodynamics is recommended to differentiate between BOO and DOA. However, when you want to operate these patients with diffuser underactivity, you can counsel the patients according to the poor outcome in these patients when they are still treated with TURP, although they have diffuser underactivity. So it's like a forensic tool. Number 13, only prostate operations will sufficiently help the patients over long term. So there's always a discussion, should you treat with drugs or should you go with an operation quickly? And these people were followed up in France, and this is health insurance data with millions of people, and they followed up these patients after the operations, after 3 months on, and they looked until 5 years, and they looked how many patients stayed without treatment and found out that 5 years after TURP, 40% of those patients with TURP were treated with drugs again. These were prostate drugs, plans, 5-alpha blockers and alpha blockers combination therapy increased from 6% after month 4 to 25% after year 5. And even bladder drugs, antimuscarinics, there was a chance of 14% after 5 years. So that means that in 60%, the TURP or the prostate operation is not sufficient to cure the symptoms. Some surgical techniques are better than others. Then some people say, I do, for example, a HoLEP, and that's much better than your TURP. Let's look at some randomized data. You can see here international studies comparing monopolar, bipolar TURP, that means same inclusion, same exclusion criteria, or TURP against TUIP, open against TURP, HoLEP against open prostatectomy, green light laser evaporation against TURP, or TURP against tuna. And here you can see the preoperative and the postoperative data, and you can see between the groups there is no significant difference. But this doesn't matter because there's a different operation. But when you compare the same group of patients, all prostate operations, taking away the prostatic tissue, do likewise, do the same. Then some paper, fake news number 15, that's the last one. Some people say it's better to operate the patient soon because then they are asymptomatic. And I'm taking the same studies again. And now look at the post-operative data. Asymptomatic means they have an IPSS of 0 or 1. But you can see these patients after the operation still have an IPSS of 7 in this study, or in 5 in this study, or 6 in that study. So you can see no patient is actually asymptomatic after the operation. They are only mildly symptomatic. And that's very, very important when you counsel the patient after the operation. So don't tell the patient is asymptomatic. Then the question arises, should I do an operation or should I go with medical treatment? And this is a very recent publications which we've done with GSK. And you can see when you have these patients, and that's the baseline IPSS, 5, 10, 15, 20, or 20, 20 or 30. And the red line is the predicted outcome without treatment. You can see that there's an increase of symptoms over time without treatment. But when you have combination therapy with tamsulosin and dutasteride, you can significantly lower the symptom load. And when you now see the IPS difference, these are absolute values on the top, relative values on the bottom. You can see when you have somebody with a highly symptomatic enlarged prostate, you can reduce the IPSS score of about 18 to 20, and that's almost the value which you can get by a prostate operation. So the combination therapy with dutasteride tamsulosin is very efficient in some patients, especially those with a large prostate who are symptomatic at the beginning. Last slide, we are almost done. Conclusion. Fake news amazingly persists in urological communities over many decades. Education on BPH still takes place, but only oral in the hospital during urological training, and then is transported from John to the next generation. So no extra information, but old information is carried forward. Education on the most important topic on urology, and bear in mind it's the fourth most common disease in adult men, is actually insufficient, underrepresented on congresses and in major urology journals, deemed as an easy and clear topic. It is considered irrelevant compared to oncology. The knowledge on physiology, pathophysiology, and assessment is missing and is only integrated in clinical routine after decades. There's still the opinion a prostate operation always helps, therefore it's irrelevant what I do before. And especially in Germany and other systems, there's a clear disconnection of outpatient assessment. These are office urologists, and inpatient treatments. These are the surgeons. And the results of prostate operations are not carried forward to the home office urologist who primarily evaluates the patient. Thank you very much for attention. That is an article I've written with two colleagues. It's a German article. It was published in the German Journal of Urology, and it's translated "Consistent Myth of BPH and What is Actually True." So it was summarized in German language, and most probably it's necessary to summarize it in English as well, because I think it's a worldwide problem. Thank you very much.
Thank you very much, Matthias. Now I want to open to the question. Some question for the floor?
Are you shocked? Are you shocked now?
Yes, I'm still a little bit confused because everything's fake. I don't know how to treat my patient now. No surgery.
No, actually, it's very easy. Carlos, I believe you're one of the good guys and evaluate everything separately, especially when you do many urodynamics and determine the bladder outlet obstruction grade. That is clearly a good choice.
I like to ask to Dr. Avilez, as our pathologist, have a big experience in study of prostate, and had many autopsy study. What is the size of prostate of our patient here at Unicamp? Yeah, because Matthias said about 8 to 40 grams normal. What you see in our post-mortem patient size?
I had a study about that. In our patient autopsy study, it ranges from 15 to 30 grams.
Yeah.
It was about 100 autopsies. That was the weight.
Yeah.
So very similar for your data, Matthias. Thank you.
Yeah.
So,
no, we do the mistakes because we always take the average value, but we don't see the range of the values. Okay. On average, it's true, it's 20 plus minus 5 or 6 grams. But in individual patients, it might be smaller or bigger without a disease.
Okay, you say about the very the the paper of Thomas, don't do surgery in patients hypoactivity of the trusor. But nowadays, many papers from the Korea and Japan, they present a good results perform surgery, especially
Yes.
about enucleation.
Yes,
So,
true.
in your mind, these results?
Yeah, but these data published in these, especially from Asian countries, they have short-term outcomes, 12 months, 36 months. These are no long-term outcomes. That's the difference. Number two, they put in a group of diffuser underactivity also these patients with bladder artery obstruction, because you can have a combination of bladder artery obstruction and diffuser underactivity. What Thomas did in this working group, they looked on pure diffuser underactivity in the long term. The Korean studies and the Japanese studies, they have partially BOO in there. And when you have BOO, you have a better outcome than diffuser underactivity only. That's the difference.
Very, very good point. How you perform a diagnosis of hypoactivity and urinary tract obstruction. You work with a lot of Maastricht, Hanover, nomogram. So you use this nomogram?
Yes, we frequently use it, and we use it for a certain purpose. We have published a nomogram based on bladder outlet obstruction index and contractility, and we use the maximum Watts factor. And you can see the percentiles, and we know that somebody below the 25th percentile has clear diffuser underactivity, and if he's below the 10th percentile, this patient is an unsuccessful TRP, and he is not a good candidate for neuromodulation. What we have to do, actually, we have to do urodynamics to have these values. And if you doubt, for example, patients with a small prostate, high bladder volume, high PVR, it's very doubtful that that patient has obstruction. There you go for urodynamics and evaluate if he has bladder outlet obstruction, diffuser underactivity, or combination of both.
Great. Cassio, I have a question.
Yes, I have a question. Hello?
Yes, we can hear you.
Okay. Thank you. Nice presentation, Professor. It's really lead us to think about what we're doing with our patients. But after our presentation, I'm wondering if we have to make our decisions based more in a clinical setting or based on objective examinations like ultrasound and aerodynamics. So, how you do in your clinical practice now? You valorize more the clinical presentation or aerodynamics or ultrasound?
It's actually a combination, right? It's actually a combination. When you have somebody who complains about symptoms, you can objectify this with an IPSS, for example. But if the patient tells you, I'm bothered by the symptoms, and that's not a bad symptom, then the patient is always right, he wants treatment. But I trigger the treatment according to objective findings. Uroflowmetry, the questionnaires, post-void residual, ultrasound investigation, and also urodynamics. And I don't do urodynamics in all the patients, but when it's very suspicious that somebody does not have a bladder outlet obstruction, I do urodynamics to quantify diffuser underactivity or find out the root cause of the symptoms. Please bear in mind that we have a very elderly population in Germany, and we have about 20% aged 65 years or older. And these patients do not only have big prostates, they have neurological diseases, they have Parkinson, they have a stroke and whatsoever. So it's not always very clear if he has pure obstruction or it's a combination of other factors. So in all those patients where it's doubtful, I do urodynamics, and in total we do about 400 to 500 urodynamics per year in my hospital.
Yeah, urodynamics is always a safe port for all of us. But I think we still do not have a clear definition about the causal relationship between some urodynamic findings and some clinical symptoms. Do you agree with this or not?
Partially. What you have is, of course, you can have bladder outlet obstruction, and that is something you can measure very clearly. You can have diffuser underactivity, which you can clearly measure. And you have also the combination. You have different grades and different or variable patients with different subtypes. So there is clearly a good indication for treatment. Don't do any assessment without the consequence. So if you don't consider treating these patients or don't do a TURP, don't do urodynamics. It's worthless because it's an academic exercise, interesting, but it has no consequences. I think there is always a good explanation for the symptoms when you do urodynamics. I always find a very good correlation between symptoms and findings.
Perfect.
Nice message. Thank you.
Yes, I have a question for Lucas. Please, Lucas.
Thank you, Professor. Very nice presentation. I'd like to ask you about those new methods, minimal invasive for treatment, surgical treatment of BHP. How do you do that in Germany? How's your experience? For us, it's the same as you. We don't have those covered by health. So I'd like to know, when do you perform? And about the ejaculation, the retrograde ejaculation, do you think this is an issue that was always there and nobody was talking about it before, or is just a fake news of the moment?
No, that's an excellent comment. When you don't have a choice and you always have unejaculation after an operation, then you don't have to discuss it. You have to tell the patient, but don't have to discuss it because that is the consequence of the operation. However, when you have now operations that don't have the consequence, and it's like ejaculation spurring, like a partial TURP, ejaculation TURP, I-10 system, Urolift, partially resume, then you have to mention that. And then patients come out and say, yeah, actually, when you ask me, then it's important for me. And these are not only the patients who are 52 years and have a young partner who wants to become pregnant. Even the older men, and especially the Muslim community, they like to ejaculate. The Muslims, I don't know if it's the same in Brazil, ejaculation is a sign of manhood. And if you don't ejaculate anymore, you're no man, no real man anymore. So for Turkish or for Muslim people in Germany, it's extremely important that they preserve ejaculation. The first part of the question I forgot now.
If you do, usually those
I remember now. There's almost nobody who does the entire variety of operations. You cannot do that. You cannot provide these 15, 20 types of operation. You need a good strategy. For a normal size prostate, that's TURP. For large prostate, you do a HoLAP. For ejaculation sparing, you do Urolift. So you have to classify according to patient groups and just pick one of these 2 or 3 operations you provide in your hospital. If a patient wants a different operation, go to a different office, go to a different hospitals. We are free to send anybody to a different hospital when he doesn't want our operation type.
Our last question to you, Matthias.
Carlos, there was a small pause at the very beginning. Please repeat.
You present if you do a partial TURP or radical TURP, the same results. How you compare TURP and enucleation, like HoLAP? So the same results, quite perform HoLAP, do just a tunnel is enough.
Well, you can do in everybody a TULAP because it's a complete removal of the transition zone. it has to be whole lap or two lap is no difference. It's a complete removal of the transition zone. The question is, do you really need it? And can you do a more or a less invasive procedure where you remove only the transition zone partially? And the scientific results, and that's not my personal opinion, the scientific results show it's equal outcome. I personally think over long term, there will be differences between partial and complete TURP, but in science, it's not important what I think. It's important what has been published. And that is the only thing that's published. And therefore, you have to doubt that you have to do complete TURP or whole lap or two lap.
Okay, thank you very much, Matthias. It's a great pleasure to have you in our meeting. Very good talk, and we want to thank you again. I invite everybody for the next meeting next Wednesday. Thank you very much, and have a good day, everybody. Bye-bye.
Okay, thank you very much for the invitation. Bye-bye.
Bom, muito bom. Acho que foi bastante desafiadora essa aula, hein?
Ah, muito difícil. Do jeito que ele fala, não dá para fazer nada.
Nada. Nós estamos...
Mas ele usou umas referências antigas, né?
Leonardo, podia parar de gravar? A gente vai só discutir um pouquinho. Acho que poderia pegar uns 5, 10 minutos para discutir entre nós, mais fácil. Nós temos os internos aí. Vocês têm alguma pergunta? Alguns estão meio quietos aí?
Eu entendi muito bem uma parte que ele correlacionou direito